Please note, the opinions expressed in this podcast are those of the individual speakers and do not necessarily reflect the views of Tri-County Orthopedics. Any medical advice or treatment recommendations discussed should always be reviewed with your own healthcare provider. This podcast is not a substitute for professional medical advice, diagnosis, or treatment.
Welcome back to the OrthoZone podcast by Tri-County Orthopedics. Today we are excited to have Dr. Jonathan Shearin on the podcast to talk all about carpal tunnel syndrome. Welcome, Dr. Shearin.
Thanks for having me.
Before we dive into today's topic, can you tell the audience a little bit about why you became an orthopedic surgeon, a little bit about your training, and then how you ended up here at Tri-County?
So my father was a pediatrician, so he got me into medicine and caring for people and taking care of people. So I would see him when I was growing up, being on call at the hospital and hearing about his patients and his experiences traveling and caring for children. And that really excited me. And then I was fortunate enough to volunteer when I was in college at Georgetown in the pediatric ward, and I spent time volunteering. And I realized at that point that medicine was my calling and I wanted to help people. And coupled with that, fortunately, I was able to take anatomy and physiology classes early in college and recognize that my love for science and anatomy coupled with caring for people was the perfect mix for me, which is why I pursued medicine. Medical school, I went to Georgetown. Residency, I went to Lenox Hill Hospital in New York City for orthopedic surgery. And then fellowship, I was at the Rothman Institute Jefferson Hospital System in Philadelphia for my hand and upper extremity fellowship. I ended up at Tri-County very early in my career because I was drawn to the practice, the surgeons, the pursuit for excellence and caring for patients, the camaraderie between the staff and the team. And when I visited and interviewed, I realized that this practice and this business was truly motivated by helping people, helping patients get better, helping athletes get better, helping everyone who's injured and hurt themselves get better and get back to what they want to do in the most effective and safe way. So to me, this practice made the most sense, and I was very happy to be offered the position, and I've been very happy here the last 5 years.
Well, we're very happy to have you here at Tri-County with us. So today's topic is carpal tunnel syndrome, as well as carpal tunnel release surgery. I thought we would start off the discussion with you telling us what carpal tunnel is, as well as how you diagnose it in your patients.
So carpal tunnel is the most common compressive neuropathy of the upper extremity. So what that means is the nerve, which is the median nerve, is compressed in the wrist, leading to increased pressure in the carpal tunnel and decreased nerve function. So by definition, carpal tunnel is increased pressure within the carpal tunnel, which is in your hand and wrist, which is causing decreased function of the nerve. Additionally, diagnosing carpal tunnel. So diagnosing carpal tunnel is really truly a clinical diagnosis. So what that means, diagnosing carpal tunnel depends on, number one, the history. So what the patient tells you about their symptoms, nighttime symptoms, numbness, tingling in the median nerve distribution, pain at night, weakness. So number one, history aids in diagnosis because this is a clinical diagnosis. And number two, the physical exam. So there are certain physical exam maneuvers that I, as a hand surgeon, will assess in order to confirm carpal tunnel syndrome. There are other things that can be done, such as nerve conduction studies, which you don't absolutely need for your diagnosis, but they can aid in the diagnosis in order to confirm, rule in or rule out carpal tunnel syndrome. And oftentimes I will order a nerve conduction study in order to confirm my diagnosis. Not always, but a lot of the times.
Now that we know a little bit about the syndrome and how you diagnose carpal tunnel, can you describe common symptoms that patients experience, as well as if patients are able to self-check?
Those are great questions. I think because this is the most common thing that I see in the office, it's very easy to be able to detect this. Patients come in with numbness and tingling in the median nerve distribution. Now remember, the median nerve is the nerve that's affected by carpal tunnel. So they can have numbness and tingling in the thumb, the index finger, the long finger, and one side of the ring finger. Oftentimes they'll complain of a lot of nighttime pain, nighttime numbness, and really nighttime discomfort once they go to bed. They also can report a weakness in the hand where they're dropping things at home. So ways to self-check is you really want to kind of evaluate day to day what you're doing. Are you having difficulty with what you're doing? Are you having any numbness? Are you dropping things? Do you have any weakness? And what are your symptoms at night. Now, when I said this is the most common thing that I see, there are still some demographics that we see more commonly. We see it more commonly really in women. We do see it in ages around 40 to 60 are the more common ages. We can see it associated with certain conditions such as thyroid dysfunction, diabetes, and pregnancy, as well as autoimmune disorders. That being said, while carpal tunnel is associated with those conditions, most of the time my patients do not have any one of those specific conditions.
Okay. So something I didn't know is that carpal tunnel doesn't just affect the hands. You can also have it in your wrist and in your arms. Is that correct?
That's correct. So what you see, most commonly you see it in the hand within the carpal tunnel where the pressure is increased for a variety of reasons. And that can lead to symptoms in the fingers, but also it can lead to symptoms in the forearm, elbow, and even higher up towards the shoulder. So it's not uncommon for patients to have radiating pain to the fingers and also radiating pain to the elbow and the shoulder.
So when someone starts experiencing some of these symptoms that you just described, when is it time to come see a specialist?
So in my opinion, I think that anytime you're noticing or appreciating something that's abnormal or different for you, you should either alert your primary care physician or see a specialist. Healthcare and our health are really the most important things that we should value and prioritize. So therefore, if you notice anything different or unusual, please come in and see us or see your primary care physician. Whether or not there's tingling, numbness, weakness, all these things, sometimes they go away. If they go away, fantastic. If they don't go away, you have to let us know.
And how often are you seeing carpal tunnel within your own practice, would you say?
So as I mentioned earlier, this is really the most common thing that I see. They report that in the general population, carpal tunnel is seen from anywhere from 2 to 5% of the general population. Because what I do is only hand, wrist, and elbow surgery, I probably see it upwards 10, 15 to 20% of the patients that walk in my door have carpal tunnel.
So at this point, we've covered symptoms, diagnosis, when to see a doctor. Let's move into treatment options. We can start with conservative treatment options, and then we'll get into our discussion about carpal tunnel surgery.
Great question. So I think number one is you want to think about activity modifications. So what that means is, are you doing anything during the day where you notice the symptoms worsen? And in that case, you want to try to modify those activities or don't do those activities as much. So that's number one. Number two, splinting is a huge form of treatment for carpal tunnel, because what that does is that helps to put the nerve in a safe, healthy position. We see at night patient's symptoms are worse because the wrist can go into positions where the pressure inside the carpal tunnel can get slightly increased. And that increased pressure in the carpal tunnel, because of the position of the hand and wrist, can cause symptoms. So that's why splinting at night is very important. But I also tell my patients, if you're having symptoms during the day, also try the splint during the day. Additionally, we can think of oral medicines. So oral medicines such as oral steroids, oral anti-inflammatories, or even therapy. So occupational therapy and home exercises, we call these nerve glides or nerve gliding exercises. These help alleviate pressure within the carpal tunnel, and these can at times help to alleviate patient symptoms. So I generally will give out a home exercise program or even a prescription for hand therapy to work with a therapist on these exercises. And kind of the next step is thinking about a cortisone injection. And that's a cortisone injection that we can give in the office. It takes about 2 or 3 seconds, and that can be given into the carpal tunnel.
And usually if you're giving someone a steroid injection, are they also at the same time doing the oral medications and the splinting? Is it kind of all at the same time?
Often, yes. Oftentimes, I will try to approach it in kind of a multifactorial type of way with activity modification, splinting, exercises, plus or minus a cortisone injection.
And I want to ask, how successful do you find these treatment options, or is it that most people end up just needing the surgery?
I think that's a really good question, and I think it really depends on the severity of the symptoms. So are you a patient who's coming in with mild carpal tunnel, who has minimal symptoms, and it's been going on for 2 weeks? Or are you the patient who's had symptoms for 2 years, who has persistent numbness and tingling and weakness? Those are very different categories of patients, where the former patient who has mild symptoms, short period of time, would likely have a higher benefit from a cortisone injection than the patient who's had it for a long time and has already developed weakness and persistent numbness. The literature says that for mild carpal tunnel, about 50% of patients will get better at 1 year with the cortisone. That means the cortisone has the potential to cure half the patients who have early carpal tunnel syndrome.
Do you see that in your own practice, that for the patients that get cortisone?
I do, absolutely. Whether or not it's mild or severe, patients do get relief from the cortisone 100%. So if your symptoms are bad, absolutely. But I found that successful or curative treatment of carpal tunnel from a cortisone injection can be found when the syndrome is mild.
So I kind of want to know your opinion on patients that aren't quite ready for surgery and they want to try some holistic treatments, whether that's acupuncture, laser therapy, cryotherapy. What do you think of these treatments?
I think that anytime we approach a condition that's so common, it's important to have a variety of modalities so that we can cater to everybody. I think that topical creams can be effective. So what Voltaren is a type of cream that can be used. It's an anti-inflammatory cream, and that can provide benefit. I've anecdotally heard that some patients do get relief from that. That's a topical cream. Additionally, things such as acupuncture, cryotherapy, those also can help. There's not a lot of data or reproducible data on things such as acupuncture, cryotherapy, but I've had anecdotal stories and patients tell me that they've found relief from acupuncture. There's a little data that's looked at acupuncture and improvement in pain symptoms from carpal tunnel as it relates to acupuncture with splinting and acupuncture without splinting. And there is some data that has shown that acupuncture with splinting has helped. Now, I think we have to be very careful with certain data and the reproducibility of it. But my point is that I think if it doesn't hurt to try to see if it does help, I can't necessarily advise that it's something that's absolutely going to help. But as I said, I do like to approach this in a multifactorial way to try to give my patients the most relief and the most effective treatment for this.
So now we're going to start talking about surgery, specifically carpal tunnel release surgery and its two approaches. There's the open approach and the endoscopic approach. Dr. Shearin, could you tell us the difference between these two and which approach are you using on your patients?
Absolutely. So I would say that, as you said, Olivia, there's really kind of two approaches. There's the open approach and there's the endoscopic approach. There's additionally another approach called a mini open. So mini open, open, and endoscopic. For a portion of time in my career, I was doing the mini open approach, and I had significant success. Over the last 12 to 18 months, I've converted to an endoscopic approach, and I've been very, very happy with it. Data shows and literature shows that both approaches, the mini open and the endoscopic, are both equally safe and effective. In my opinion, I feel the endoscopic approach, what it offers patients is more pain relief earlier on in terms of post-surgical pain and also an earlier return to function and work. About 20% of hand surgeons do the endoscopic approach. The other 80% do an open or a mini open approach. I feel that the earlier postoperative period, the first day to 2 or 3 weeks, is a little bit more tolerable with the endoscopic approach. Literature and data has also shown that the endoscopic carpal tunnel release has shown patients returning to work a little bit earlier compared to the open approach. Both work very well. Both are equally safe. Both are effective. In my biased opinion, I do favor the endoscopic carpal tunnel release.
And could you walk us through the difference in surgical procedure inside of the operating room, the difference between open and then endoscopic?
Yes. So with the open approach, we make a small incision in the palm and we release the pressure on the carpal tunnel by releasing the ligament. That surgery takes about 5 or 6 minutes. With the endoscopic approach, we make a small incision in the wrist crease about half the size and we put a camera in. With the camera, we visualize the transverse carpal ligament, which is causing pressure on the nerve, and then we release the ligament with a small knife under direct visualization with the camera. So that's how the surgery differs. The endoscopic is about 5 minutes as well. Both can be done either awake or under light sedation or asleep, whatever the patient prefers. And it's an in and out type thing where you come in the morning and you go home the same day. Additionally, I think understanding what makes somebody go to surgery, when is surgery needed, when is surgery indicated. I think when there is a complete failure of non-surgical treatment with everything we discussed, splinting, oral medications, injections, and the patient still remains symptomatic, it's very appropriate to proceed with surgical intervention. Additionally, if patients come in with impaired neurologic function, they have weakness, they have persistent numbness, they have disabling pain, these are other indications where surgery can be offered as an option.
We're going to get into recovery now, which is always a topic that a lot of patients have questions about. So what is the recovery like for carpal tunnel surgery? And is there a difference in the open versus endoscopic recoveries?
I generally tell my patients that the recovery is anywhere from a couple days to a couple weeks, and that's fairly variable. So I think for the mini open and the endoscopic carpal tunnel release, if you look at patients at 4 weeks or 6 weeks or 8 weeks, they're going to be the same. So the recovery will be the same. I think the earlier recovery for the endoscopic carpal tunnel release is a little bit quicker and a little bit less pain, as I said earlier, with an earlier return to work. But I would say on average, the literature shows that if you're doing light sedentary duty or desk duty, it can be within a couple days up to 7 days. If you have light manual work, a little bit heavier work, we're thinking maybe 14 days to 21 days. The literature shows that for heavy laborers, manual laborers, after this procedure, it's about 30 to 40 days. I think it's a little bit earlier for the endoscopic carpal tunnel release as compared to the open for the manual laborers and the heavy laborers. But generally, most patients are back to early activity, typing, computer work, exercising, doing their hobbies fairly quick. This is not a significant inconvenience to their life, and it can make a huge benefit in terms of sleeping, in terms of function, in terms of using their hands. I've had so many patients tell me how pleased they are they had the surgery. This is one of the surgeries that is very reproducible, and patients are very, very happy, and they're very appreciative and grateful. That's what makes my job so exciting and so rewarding. When we have a problem, it can be fixed, and the patients are grateful and they're very happy.
One more question for you. Do you ever have a patient where you perform carpal tunnel surgery, they recover, and then in a couple months or a couple years, they come back and say their carpal tunnel has returned?
I do see that, Olivia. It's fairly rare to see that. I'd say on the order of, 3% up to 15 or 20% can be reported in the literature. And when you think it does come back, you really have to take a thorough and varied approach to diagnosing why the recurrence came back, which can involve further imaging studies, further nerve conduction studies, and other ways to diagnose recurrence. I'd say it's fairly rare, but it has happened. A lot of times patients also will ask me, Doc, what else can I do? And I know we talked about that a little bit, Olivia, in terms of splinting and oral anti-inflammatories, oral steroids. But a lot of patients ask me about diet. And I think it's hard to say whether or not diet absolutely does or does not make a difference. But anecdotally, I have had patients who try to practice a low inflammatory diet. And what that means is leafy greens, salmon, kind of a Mediterranean diet. And what they've shown is that this diet actually promotes decreased inflammation. And so theoretically, they have had some relief in their carpal tunnel symptoms. On the same token, decreasing inflammation in your body with avoiding heavy, salty food, avoiding fried foods, saturated fat, all these things. Because if you recall, when we started, the carpal tunnel is a very tight space. And any change in pressure to that tight space can put more pressure on the nerve. And so increasing your volume, increasing your fluid, salty foods, saturated foods, things like that can increase the pressure in that space, thereby worsening your carpal tunnel symptoms.
I think we have to wrap up this episode now. That's all the time we have left today. But I want to thank you, Dr. Shearin, for coming on the podcast.
Thanks, Olivia. I'm really glad I could be here. And if anybody has any questions or concerns, please come visit us at Tri-County.
As always, we will have links to all of our social media, our website, all the places you can find us, and stay tuned. The next episode is going to feature Dr. Klein. He came on the OrthoZone podcast and he talked all about broken bones and fractures, and it's a really great episode. So stay tuned for that, and we'll catch you next time.
If you enjoyed today's episode, be sure to subscribe so you never miss an update. Don't forget to share the podcast with others who might find it helpful, and follow us on Facebook and Instagram at Tri-County Orthopedics to stay connected. Thanks again for tuning in, and we'll catch you next time.